It's my privilege today to introduce today's speaker, Dr. Lori Orlando. She's a professor of medicine and director of the Precision Medicine program in the Center of Applied Genomics and Precision Medicine at Duke University. She attended Tulane for both medical school and residency, where she not only survived the humidity of New Orleans, but she thrived as well, earning induction into the AOA and numerous teaching awards. She served as chief resident, after which she completed a health services research fellowship at Duke University Medical Center. She received her Master of Health Sciences from Duke's Clinical Research Training Program. From 2004 to 2009, Dr. Orlando worked in the Center for Clinical Health Policy Research, where she focused on decision modeling and technology assessments. As mentioned earlier, she's the director of the Precision Medicine program, where she's been leading the development and implementation of MITRI, which is a family history-based risk assessment and clinical decision support program to help primary care physicians like me guide clinical decision-making. Dr. Orlando has over 90 publications, over 40 abstracts, secured extensive grant funding, and is an international speaker about optimizing disease risk. She has generously given us her time today, so please join me in welcoming Dr. Lori Orlando.
Thank you. Is the microphone working? Yes. Okay, great. Thank you. I'm pleased to have been invited. This is my favorite subject, and I enjoy teaching people about why we need to start thinking about genomic medicine as part of our routine care. And so we're going to walk through a couple of the foundational reasons why I believe that to be the case, and we can talk a little bit about how to go about doing this in the future. So one disclosure, I am the founder and president of a company around the family history platform that we were just talking about, and it's really not part of this talk today. So genetics versus genomics. Who here feels like they know the difference between those two things? No hands. Okay, great. We're going to talk about that. The genetics is what we all learned in medical school about the BRCA gene and these highly pathogenic variants that have very high risks for disease associated with them. They are both DNA-based tests, but genetics is the study of a single gene. So like the BRCA gene and mutations within that gene that might cause the protein to be non-functional and lead to a disease state. They typically have traditional Mendelian inheritance patterns. They're monogenic, meaning it's a single gene. They're high penetrance, meaning that they're very likely to cause disease. And they're rare, quote rare. Rare is now probably far more common than we used to think rare was. And on the genomic side, we're talking about things like polygenic risk scores. We'll come back to that in a little bit, but these are also DNA tests, but they're looking at all of the genes across the entire genome. They have no real inheritance pattern associated with them. They have very low penetrance. So back when I was starting out, New England Journal of Medicine used to publish an article every week saying this SNP is associated with this disease at 2%. And that doesn't change anything that we do on the clinical care scenario. But over time, they started to add those genes together and create these polygenic risk scores, which have a stronger impact on associations with diseases, although they're still not as strong as a monogenic disease. So we're going to talk about DNA. We're also going to talk a little bit about RNA. But to start, DNA comes in a variety of tests. So genotype, a targeted gene sequence where we're sequencing a single gene, a whole exome where we're sequencing all of the genes, and a whole genome where we're sequencing everything. And those are increasingly more complex as you go down that list, but they also provide more information as you go down that list. And I'm going to talk about the genotype specifically in just a second. But what's really important to know about these is, one, we're talking about germline here. We're not talking about somatic. So somatic is when we're things like tumors, where we sequence a tumor. We're not talking about that. We're just talking about our germline. And the other thing to know is that regardless of which of these tests we use, we are comparing the results of that test to a reference genome. And that reference genome is comprised of a bunch of volunteers who gave their sequences early in the process, and they put them together and said, this is what a normal genome looks like. These are largely Caucasian males. And it's really not what the genome looks like. And so we've come a long way in understanding that we need greater diversity in the reference genome in order to better understand what a normal genome is. In about 10 years ago or 8 years ago, there was a classified as a pathogenic mutation in cardiomyopathies. And unfortunately, they had no African Americans in the data set in which they identified this as pathogenic. And they went out and put it into clinic, and they started telling all these people that they had a heart genetic defect. And it turns out that it's a normal variant in African Americans, and it's quite common. So they diagnosed all these people with cardiomyopathies of genetic origin that were not. And since then, they've become a lot more sensitive to the need for greater diversity in the genome. One of the reasons that happens is because over our evolution as humans, there were pockets of people that got isolated from the rest of the humans, and they created environment. They had environmental pressures that led to certain variants in their genome that helped them adapt to their environment. And hemoglobin S is a really good example of this, protects against malaria in regions with high malaria. ApoL1 is another example of that for African Americans who lived in West Africa. It protected them against African sleeping sickness. Unfortunately, when you have two of those on each DNA strand, you end up with a higher risk for certain diseases. So having that information from a broad range of individuals really helps us better understand what's normal and what's not normal. All right, genotypes. So genotypes are when you look at, instead of every base pair in a gene, you go, okay, I know that base pair 13 and base pair 25 and base pair 1000, we have known variants that cause disease. They cause the protein to not work. It leads to disease. So I'm just going to look at what you have at base pair 13, 25, and 100. I don't care about anything else in between. And so you get back just a report that says 13 is normal, 25 is not normal, 100 is normal, or 1,000 normal. And it's done on an assay where they just had selected probes for those specific variants. So they don't actually know anything about the other positions in the gene. They only know about those. So what's important about that is if you get a genotype done, you can never reanalyze that information. A new test must be ordered. And this is particularly relevant in clinical practice today. So we're going to talk about genetics and genomics. We're going to talk about RNA and its application as well. The purpose of testing is across the spectrum of human health to disease. We can use it for risk assessment. We can use it for diagnoses. We can use it for prediction of disease risk or outcomes, and we can use it for treatment. And the goal here is that by implementing genomic testing at the right point in time, we will shift the curve so that we keep people healthier longer and the costs are lower and the life expectancy goes up. So we can use genetic tests for risk assessment, for diagnosis, and for treatment. And specifically targeted treatments, which we'll come back to. So risk-based testing, this is the greatest impact for genetic testing there is. This is the largest group of people, the highest number of people with abnormal variants. And it's where in internal medicine, we will be seeing the majority of the patients with these, where testing is needed. So these are usually healthy people. You typically will identify them based on a family history. And there are clear actions that we can take based on the identification of certain gene mutations. So we can implement better screening. We can implement different preventative measures, different medications, things like that to help keep them healthy. When we say that someone has hereditary breast and ovarian cancer syndrome, that is not a diagnosis, that's a syndrome, and that syndrome increases risk for developing breast cancer, ovarian cancer, pancreatic cancer. So it's not a diagnostic test, even though it often gets confused for one in that setting. So 20% of the general population meets criteria for risk-based testing. 20%. You just think about that. Like, how many people have you guys seen in clinic? And how many have been tested for one of these hereditary syndromes? I'm sure not 20%. It's really hard to do risk assessment in clinic. It's time consuming. It requires gathering and analyzing complicated data. And we often think that we'll know these people when we see them, but we don't. So it's a huge number of people. 12% of those people end up having a pathogenic mutation. When we've done genetics first screening studies, where we don't gather family history, we don't do anything, we just go out and screen everybody who walks by on the street, they found that about 5% of people have a pathogenic mutation. But interestingly, only 50% of those actually meet criteria for guideline testing. So we're missing people not only because we're not identifying them based on guidelines, but also because there's a whole lot of people who don't actually meet the criteria for the guidelines. It does change their care, and it enables cascade screening for their relatives, which is important because that's what, that variant isn't just about that one person, it's about their family members, and about their family members and their family members, and it just cascades out across the whole US population. So it's really important to identify these people and then get them treatment and get their family members tested in order to stop that cascade. But like I said, it's super hard to do this. This is where I've spent a lot of time on my research and developing tools to try to make it easier, but it's just really practically impossible to do in the setting of a routine clinic appointment. So here's a really good example. I had this patient come in to see me in my clinic. She was 40 years old. She was healthy. She said I'd had endometrial cancer. She had her uterus taken out, and they told her she was cured, and she went on her way. And that was at 37. And she had actually asked the GYNs, hey, I have this family history of colon cancer. I'm really worried about that. And they were like, yeah, we don't do colon cancer. And so she came to see me, and we started talking about her family history, which you can see here is horrible. Absolutely horrible. And no one in the family had ever had anyone talk to them about genetic risk before. So we tested her. She has a pathogenic variant in the MLH1 gene, which is associated with Lynch syndrome. And because she'd only had her uterus taken out, not her ovaries, so the Lynch syndrome is associated with colon cancer, with ovarian cancer, pancreatic cancer, prostate cancer. So now we're worried about her ovaries. We're worried about her risk for colon cancer. So we start screening. She actually undergoes a oophorectomy. They do cascade screening in the family. Turns out the maternal grandmother is the source, and that maternal grandmother had 10 children. There were a lot of people affected in this family. And interestingly, she has a twin sister, identical twin sister. So that sister by de facto had that genetic mutation as well. She was wanting to get pregnant, had not had a child before. And so she delayed treatment until she could have a baby, and she developed colon cancer while she was pregnant. And they had a brother who just said, I don't want to know. Don't talk to me about this. And so that's not terribly uncommon response in families. Some people just don't want to know. So it's complicated. So because it's so hard to do this in clinical care, they've come out with population screening recommendations. So the CDC has what we call tier 1 screening recommendations. You do not need to meet criteria based on a family history, personal history, or any other thing. You should just screen everybody who walks in the door for these 3 conditions. We do not do this because insurance will not cover it, even though the CDC and other guidelines say that it should be covered. If we want to do this, we have to understand how to do it in clinic. That's the other thing, because we're not trained, during our residency or medical school on how to talk to patients about doing this kind of testing. But it is one way to make this simpler. There's a Nevada project. It was a partnership between Helix and several health systems in Nevada where they screened everybody. They had almost 27,000 people that got screened in that health system, and 1.3% of those people had a pathogenic variant in one of these genes. And interestingly, 70% of those people already had a disease associated with that syndrome, and most of them had not been diagnosed. So that's one way to approach it. Another way to make this simpler is we're calling it point of care testing, but everybody got really confused by point of care, thinking it was like a tabletop device in the clinic. So now they call it mainstreaming or sometimes streamlining. Neither of those are actually very clear either. But what it is you have cancer. You have one of these three cancers, pancreatic, ovarian, or aggressive prostate cancer. We test all of those patients for specific genes that can be used to guide treatment. And those genes happen to be genes that also are associated with hereditary conditions. So they're the same genes that are in HBOC, in Lynch syndrome, and a few others. So in this scenario, you are not to counsel the patient, get consent, do any of that complicated stuff, talk to a genetic counselor. You're supposed to just test them. And that's why they call it streamlining. But again, this is something that is different from the way care is normally provided in the oncology clinics. And so it's not always happening the way it should, but it is gaining a lot of traction. And what happens a lot of times is I have pancreatic cancer, I'm being treated for it, they test me, and it says I can get this drug to treat my cancer. I'm all for hearing that, but I don't really want to hear about the fact that I'm more likely to develop these other cancers while I'm in the middle of my pancreatic cancer treatment. So it's not the best time to be having discussions about inherited diseases. And again, these patients will often circle back into internal medicine, and then that is a good time to have that conversation. Okay, switching to diagnostic testing. So typically what happens is these are patients who have myriad symptoms. They're gone through the workup. We have no idea what's wrong with them. Some of the times these patients have been on diagnostic odysseys for years. And when we look at patients like that, we can do whole genome or whole exome sequencing and often come up with an answer to that. There is a network called the UDN, which is the Undiagnosed Disease Network. It is funded by the Common Fund from NIH. And there are, I don't know how many sites now, maybe 6 or 7 sites around the country in a sequencing center. And what happens is if you have a patient on this diagnostic odyssey, you can send the information over to one of the UDN sites. And if they accept the patient, then they will do the sequencing and will often come up with a diagnosis for the patient. This has been going on for about 10 years now, and it's been incredibly successful for these patients. About 33% of the time, they'll come up with a diagnosis. In another scenario in which diagnostic testing can occur is when you have genes that have 100% penetrance, meaning if you have a genetic mutation, you're not at increased risk, you are going to get that disease. There are not that many of them. And I just found out that Huntington's disease actually has a low penetrance version of the repeat. So Huntington's, I guess, isn't on this list anymore. But there's just a handful of them for which it's truly diagnostic with 100% penetrance. The last scenario in which you might do diagnostic testing is in a condition which you can diagnose clinically, but it isn't always entirely clear clinically whether they have that condition or not. You can add genetic testing for certain conditions to support your diagnosis. And so hereditary hemochromatosis would be a really good one for internal medicine clinics, where if you have the pathogenic mutation, it will confirm that they have that condition, but if they don't have it, it doesn't really give you, it doesn't really rule it out. So I just mentioned the UDN, and again, wildly successful. So 50% achieving a diagnosis, and they actually have identified 31 new inherited conditions in that network just since its inception because of this close collaboration between the clinical sites and the sequencing center. There's also whole genome sequencing of sick infants in the NICU. I don't know if you guys have one of these programs or not, but essentially started at Rady Children's Hospital in California by Stephen Kingsmore. They took all the really sick NICU babies who they could not come up with a reason for why they were sick, did trios. So they did whole genome sequencing of the parents and the child, and they were able to identify a diagnosis in 40% of those children, and in half, they were actually able to change their care to treat the disease. it's pretty significant actually now. This is primarily happening outside of research now. There's lots of places that are just doing it as part of clinical care. And then another good example is people with complicated seizures. About 33% of those can get a diagnosis if you do whole exomes on them. So good examples in internal medicine clinic, maternity onset diabetes of the young. So this is a genetic form of diabetes. It represents about 5% of the diabetic population. So it's not a huge percent, but given how many people who have diabetes, there's a large number of people. What's interesting about MODI is that it changes the way you treat patients. So if a patient comes in and they look like they have prediabetes, or it looks like they have traditional type 2 diabetes, and you're going to put them on metformin, some of these patients actually need to be treated with insulin and not metformin, and some of these patients actually shouldn't be treated at all. And so, having this additional information can guide the way those patients are cared for. Cardiomyopathies is a emerging area with a lot of hype right now, especially around amyloidosis because of the TTR gene, which is diagnostic and has a targeted treatment now. So doing this type of testing in clinics where we see high numbers of cardiac patients is becoming more standard of care, and because they've been missed, even at places like Duke, where we have, 400 cardiac. We have more cardiologists than we have internal medicine people, and we still miss these people. So I have I think I have a case. Yeah. So this patient came to my clinic, and he had been diagnosed before coming to me. He was diagnosed with hereditary hemochromatosis. Now he did not actually have a very high ferritin. It was only 200, so it didn't actually meet guideline criteria for hemochromatosis, but somehow they decided he had it. And they did genetic testing, and it showed that he had this S65C variant in one strand, and in the other strand, he was normal. So they diagnosed him with HH, and they started him on phlebotomies. Okay, when he came to see me, his iron was 2 and his hemoglobin was 5 because he did not have hereditary hemochromatosis. First of all, that condition is recessive, so you have to have, both strands need to be knocked out, and the S65C gene is not clearly associated with this disease. So it's sort of quasi maybe associated, but certainly not by itself. So we have to be a little bit careful too about how we use this information and make sure that we know what we're doing when we start to order the tests. I had another patient that showed up in my clinic. He was 22, completely healthy. I did an exam, and his whole belly was his spleen. It was huge, absolutely huge. And he was fine. He had no symptoms. And when I talked to him, he said his father had some sort of thing with his belly too. So I contacted the father, and he did have a very large spleen and been diagnosed with that young, and it had never caused him any symptoms, but nobody had ever explained to him why he had that. So we suspected there was something, did some ultrasounds, and the liver was also quite large. So suspected that there was probably some sort of storage disease going on in the family. Medical genetics had, a year-long wait list. So they said, here's how you order this test. And which was really trying to do a lysosomal storage disease testing was not as straightforward as I would have hoped. And came back with a VUS in a gene that was, it caused the protein to be non-functional. So it's very likely this was a new identification of a pathogenic variant for Gaucher's disease. So they do occasionally pop up in our regular clinics. All right, switching to treatment. So for genetics, targeted treatment therapies are the ones that are single gene based. Okay, so we'll talk about pharmacogenomics in a minute. That's genomics. That's looking at the whole genome and not just a single gene. So targeted treatments are a really big deal now. They're called companion diagnostics. So there's a genetic test, which is, quote, a device that goes with a drug. And when the companies develop these drugs, they they get approval for the device, the genetic test, to go along with the treatment. And there's a whole list of these now on the FDA website, but the one you'd be most familiar with would be PCSK9 inhibitors, right? But they're becoming more and more prevalent. There's lots of exciting stuff coming out for treatment of diseases that we haven't been able to treat before. It's an emerging field. It's really important. They're very expensive drugs. I'm sure if you guys are like me, I've never been able to get Repatha approved, no matter how many times I tell them that this patient needs it. But I can get my cardiologist to prescribe it for me, and they'll get it approved. So examples of these are here. So they're across cancer, cardiac disease, all kinds of the whole spectrum. And typically they are either targeting a specific gene or the molecule produced by that gene, and they're either blocking the gene or they're blocking the molecules with a monoclonal antibody. Really effective. They tend to have very few side effects because they're very specifically targeting a single gene, and so they're very well tolerated. But they mostly require being injected. Okay, so switching to genomic tests. We can use genomic tests for risk assessment and for treatment. In treatment, we're going to talk about the pharmacogenomics. So when we're talking about the whole genome, I mentioned these polygenic risk scores earlier. So we do GWAS studies, which are genome-wide association studies, where we take people who have a disease and people who don't have a disease, and then we look across the whole genome and see, are there any variants that light up that are more common on the people who have disease than don't? And so an example of that, this is called a Manhattan plot. So as you can see on the far right, that big tall line there, that is a locus where that that variant is far more prevalent in the people who have the disease. And then each of these has a very low impact. So, 2%, 3% increased risk. But when you start adding up, hundreds and hundreds of these across the whole genome, you start to get impacts in the odds ratios of 2 to 3. So these are starting to be incorporated more and more. They're actually, we were talking earlier about the Tyrer-Cuzick score. This is a risk score for breast cancer and identifies people who should meet criteria for breast MRI. That is, that they have a lifetime risk of breast cancer greater than 20%. There is now a PRS that is part of the Tyrer-Cuzick score. There are a couple other risk calculator models where they're starting to incorporate PRSs. You don't have to have a PRS, but if you have one, that is information that can be incorporated into their disease risk. I'm part of the eMERGE network, which is an NHGRI funded network where we sequenced 35,000 patients. We collected family history. We did monogenic testing, and we did polygenic risk scores for 12 different conditions. And then we created what did they call it? A genome integrated risk assessment report that we handed back to the providers and said, based on the family history, they're at high risk, yes, no, polygenic risk score, yes, no, monogenic testing, yes, no. And then following patients to see what kind of care that they end up getting afterwards and how they respond to these different elements. So becoming more and more common as part of clinical care. Pharmacogenomics is probably, outside of risk-based testing for genetics, pharmacogenomics is the next most useful right now type of genetic testing you can do that's going to impact probably almost every single patient. So it's scary complicated because these are metabolic pathways, and each drug has a different metabolic response to the same phenotype. So we classify these metabolic pathways into, with this gene, you're a high metabolizer, a regular metabolizer, or a low metabolizer. And then with that specific drug, a high metabolizer could mean the drug is given as a prodrug, it's metabolized in the liver into an active drug, in which case, if you're a high metabolizer, you're creating more active drug. So they're going to be more sensitive to that medicine, more likely to have adverse events, more likely to respond. On the other hand, if you have a different drug, it goes through the same pathway, but it's given as an active drug and the liver metabolizes it into an inactive drug. If you're a high metabolizer, this is a patient who's not going to respond to standard doses of that medication because it's getting inactivated very quickly, and they're going to need much higher doses in order to respond. And so there's hundreds of drug gene pairs. And so knowing, like, one, their metabolizer status, two, what drug it is that you're giving, and three, what the combination of those two things mean for your patient is really hard. They came up with this clinical pharmacogenomics implementation consortium where they provide guidelines around these pairs, but they're not quite well established yet. They're not at the level of, say, a USPSTF type of acceptance in the community, but they are getting there, and they continue to expand these guidelines. But this really can't be done without technology. So you need technology to help you figure out, what do I do with that drug, this genetic panel for this patient? And in cancer, it's really, really important. For example, DPYD gene is associated with a deficiency that if you give 5-FU or capecitabine or something like that, those patients are often have lethal side effects from those medications at standard doses. And so knowing that information is now becoming sort of required. And if you give that medication to a patient without that information and something bad happens to them, now several institutions have been sued. So big deal, and it has impacts across all kinds of drugs. So statins and SSRIs and pain medications. And I mean, every drug you can imagine pretty much is going to have in some impact. Some of these more significant than others. For example, carbamazepine, which is more common. These HLA variants and B variants are more common in those of Asian descent. And so in countries in East Asia and China and Japan, they actually require testing before they will order a medication like this. So an example of how impactful this can be is Vanderbilt set up a panel as just a handful of variants, and then they just set it up so that if anybody ordered a medication that was impacted by one of those variants, that an alert would show up for the provider and tell them what to do. And over a 5-year period of time, 65% of those patients who had that testing done had an alert. So it's a large number of people. All right, RNA tests are used for prognosis and for treatment. And because of the time, I'm going to skip through this pretty quickly, but omics can include the genomics, which we just talked about, which is genetics and genomics. Transcriptomics is when we look at mRNA, so the transcription of the DNA into RNA. And what that means is that a gene is turned on or turned off. So it's really interesting. They call this the expressome because of that. So it tells us about your current state at a single point in time in terms of what genes are on and what genes are off. And that gives us a lot of extra information on top of just what your genetic variants are. Proteomics is looking at proteins, metabolomics is metabolites, and then the microbiome, which isn't technically an omic, but sort of is since they live on our bodies. And so this just shows you how the RNA works with the gene being turned on or off, and then checking the levels of the mRNA for that gene will tell you whether that gene is on or off. There are quite a few gene expression tests that are available clinically. The most common one is probably Oncotype DX. It's very commonly used in breast cancer. Duke uses it for all patients with more than a stage 1 breast cancer. But there also the very common BCR-ABL translocation is tested for using RNA now. And there are several other sort of clinically applicable tests that are RNA tests that can help in guiding care. But what's super exciting is this RNA to treat diseases, right? So the sickle cell one is the most recent, really exciting. So what happens is these are small RNAs. They're called interference RNAs. And basically they'll bind to an mRNA and keep it from making protein. And so if you have a defective gene that's making an abnormal protein that's causing a problem, this can block that whole pathway. And so they've shown that at least with sickle cell, that it essentially can cure them. So we can get them early enough before they have damage and we treat them with this, then they'll never get sick. Really amazing. So currently they have trials for TTR, for macular degeneration, familial hypercholesterolemia, which at least we have the Repatha drugs already, but these are going to be RNAi drugs, and then for KRAS mutations in pancreatic cancer. And then gene editing, also really amazing. A lot of stuff coming out with gene editing. These will be cures when they're ready for prime time, and they're getting close. So a long time ago, at the very beginning of the gene editing hoopla, there was a CF trial. The very first patient enrolled in that study died, and they stopped all gene editing trials for about 10 years. So it's only been recently that they've been able to start these back up again, and I think that they've learned a lot from that first experience. All right. So what's really important for you guys, right? Knowing certain things about genetic testing to kind of help you in the clinic figure out when to do it, how to do it, what do you say to your patient, that kind of stuff. You need a framework for this, and we don't have one right now in internal medicine. And we need to know the basics, like the difference between a genotype and a sequence. And we need to understand penetrance. So how likely is it that that gene is going to cause a problem for this patient? And we need to understand pleiotropy, which is how one variant may cause a variety of different conditions. So one of the things I alluded to earlier about the genotype, that it cannot be reanalyzed. This is really important because the guidelines are changing over time, and our knowledge about variants is changing over time, rapidly changing over time. So I have had multiple patients come into me who have a terrible family histories of breast cancer, and they've said, oh, we're good. Mom had the test, she's negative. I'm like, what test did she have? When did she have it, right? 2007 was one example, and it was a genotype of a BRCA1 gene, right? We have 50 genes that are associated with breast cancer now. That's not good enough. And we only looked at, a couple variants in BRCA1 back then. Now we look at, hundreds of variants in the BRCA gene. So you have to know when you can go back and re-look at the data and say, okay, with updated information, we're still clear, or just retest them using modern panels. And what's important is that this doesn't happen with a chemistry test. It's always sodium is always a sodium is always a sodium. This is going to be going on for a really long time. Like, our knowledge is going to continue to expand at a very high rate for quite a while. And the guidelines are going to keep changing because of that. So we just kind of have to keep that in mind, that, a patient that comes in and meets criteria and thinks they've had testing or didn't know that they were eligible for testing because the guideline changed, it's something that we need to be able to pick up on and point them in the right direction. And briefly, direct-to-consumer tests. So if they show up with something from 23andMe, and the two things you need to know: one, if the test is positive, you have to get it redone in a CLIA lab, because about 10% of the time, in some companies up to 70% of the time, they're actually wrong. CLIA, research labs are not as good. They don't have the same criteria for quality as CLIA labs. So it has to be repeated in a CLIA lab. You can just repeat that single variant, and you can do that for like $50, but it's got to be done. The other thing is that if it's negative, you have to know they did a genotype test and they only looked at very specific variants. So if you did a real test, there's a whole lot of other variants that would have gotten tested, and they may have a pathogenic variant in one of the ones that didn't get checked on the panel. They usually just pick like the 5 most common variants and they call it a day. So when they're returning reports for BRCA from 23andMe, they're not actually looking across the board at all the pathogenic variants. They're only looking at a handful of them. So what could we have? What would be really amazing, and where I see, coming soon as we start to put these pieces together, is that, you're going to have a patient, they're going to come in and they're going to get a risk assessment where they're going to get their family history collected and they're analyzed, and their personal history information is going to get incorporated, and the Tyrer-Cuzick score is going to be generated for you, and all of that kind of stuff, which is the kind of things that I'm doing my research in right now. Is how do those kinds of platforms help, and what information do they need to have in them to do that? But this gets done electronically, not in the clinic. then they get tested if they need testing. And in this case, your patient gets identified as having a BRCA mutation. And so then there is a genomics clinic. Essentially, in my vision, this is what it is sort of a virtual genomic clinic where they talk about what that means and what they can do with it. And in this case, the patient elects for a bilateral mastectomy. And then it goes into a pancreatic cancer screening program where a few years later, they develop a small, they see something small in the pancreatic, in the pancreas, and they identify pancreatic cancer, and they do tumor sequencing, and they give them targeted therapy with an RNAi therapy. So this is the future. It's not that far off. It's just putting it all together and figuring out how we can do that in the setting of very, very busy practices with very little time, and not very much education about how to talk to patients about this. So, 3 minutes left. I will skip the whole on the horizon stuff and take questions. Yes.
Secondly, can you hear me? Because you can get transthyretin amyloidosis with a normal or wild type gene, and also about 5% of Black patients do have the pathogenic mutation, which doesn't cause disease. So I think we have to be very careful doing genetic tests without the proper clinical construct.
Yeah, absolutely. So I use Invitae testing for my patients, or have been, because getting insurance approval for it is very complicated. But Invitae offered a $250 panel. When I talk to my patients, I say, hey, there's a test out there that might help us understand how to take care of you better and identify risks for diseases that we wouldn't know otherwise. And there's 3 options for the test result, right? It could be negative. We could have a VUS, which means that we don't really know what it means, and we'll just watch that. Or it could be pathogenic, in which case we'll talk about what that means for you. That's the extent of what I say to my patients. We don't spend an hour long with a genetic counselor talking about, numbers that are going to go right over their head. But and then they just paid the $250 and they get the panel back, and then I follow up with them and we have a conversation, and that's great because we know each other and we feel comfortable with each other, and they're comfortable asking questions and being vulnerable, right? Because it's just kind of a scary topic. But Invitae got bought by LabCorp, and my last patient that I sent that test off for $250, they sent her a $3,500 bill. And she said, is this right? And I said, no, call them back. And she called them back, and they're like, well, that's what it's going to be as of January 1st, but we'll honor the old fee until then. So I think LabCorp is going to be making big changes. And what happens with Invitae, unfortunately, they were going to have to start putting in information to get insurance approval. Yeah, it's been, Invitae was great while it lasted. So that is, I think, going to get easier. There are a lot of, there's a RFA that NHGRI put out that I'm part of now, that's a genome-enabled learning health system, where we're actually working to try to figure out how to incorporate this into clinical practice, making it easy to get insurance approval, all of that kind of stuff. They've also just recently put out an RFA for a population genomic screening network to kind of do the same thing. So there's a lot of effort going into how to figure this out, but I don't think that there are clear answers yet. And yes, the whole thing about you got to know the disease area and you got to know what it means. Just like the guy with the hereditary hemochromatosis, we can go very wrong ordering tests on patients when we don't know what we're doing.
Other questions? So what do you suggest primary care physicians do now?
Yeah.
Is it just still refer to genetics counseling? And
I mean, you can't, right? I mean, at least at Duke, it's a year-long wait.
Yeah. Yeah.
right? And so that's why I just started doing it myself, because I was like, oh, I know this space. I think risk assessment is a great space for us to start with. And just knowing that genetic counselors are still very stuck in a model that started 20 years ago. And I went through genetic counseling when I was pregnant. I can tell you it was a horrible experience. And I know data and I know numbers and I know medicine, and it was still a horrible experience. And they do not help you with like they're trained not to help you with the decision. Like in my view, as internists, we should be helping our patients think about what information we can get back and just take it one step at a time. Like this is just about your risk. Let's take a look and we'll hold hands through the process. And so I think, a genetic counselor just isn't necessary. And there's a lot of chatbots now that we've studied in research projects where the chatbots, they're not genetic counselor replacements, they're genetic education. And their videos too. Like our hereditary cancer clinic now sends out videos to do all the pretest counseling for the patients. They just give them information on the video about what's DNA testing and what this might mean for you. And then again, we'll talk again when the test comes back and we'll figure it out together. And I think the pharmacogenomics too, but you just can't do that yourself. In your head, you cannot figure that out. It has to be built into your system.
Right.
And we're working on ways.
Because my paranoia would be ordering something and then getting they charged me.
Yeah.
Sorry.
Can you hear me?
Yeah.
Okay, thank you so much. A question about insurance. So if any of these are discovered, is that discoverable by one's health insurance? And what are the implications with that?
So there is a law called the GINA, Genetic Information Non-Discrimination Act, in which health insurance companies are not allowed to ask for that information. If they happen to get their hands on it, they can use it. But when they send over requests for medical record information, that information is supposed to be redacted from the medical record. And they're not supposed to, they can't ask for it. And so that is some protection on the health insurance side. On the life, so Harvard did a study for Alzheimer's risk. We don't generally talk about doing genetic testing for Alzheimer's risk because there's no treatment for it and there's nothing we know that will prevent it. So we don't really do that. But they did this in this study to see what people would do with that information. And basically they all went out and got long-term life insurance. And then the life insurance companies picked up on that like that. So the GINA does not protect them. The life insurance companies can use that information, and they will if they can. If they can. So you have to be careful about life insurance, but the health insurance is protected.
The questions?
In your case scenario, you mentioned pancreatic screening. What does that consist of? I'm curious.
Yeah, there are now abbreviated pancreatic focused CTs for people at high risk for pancreatic cancer. So it's a dedicated pancreatic CT. Every 5 years is pretty much what the emerging guidelines are saying. Yeah, I've done it on a few patients. Actually I had a patient with a syndrome called FAM, which is familial atypical mole and melanoma syndrome, and they usually get melanoma and pancreatic cancer. And we started the pancreatic cancer screening for her, and we actually found a colorectal cancer and early. We were lucky, but she didn't get pancreatic cancer. She got a different one.
Okay, thank you. It's my